Hi everyone, welcome back to my channel, Health by Heather Hirsch. If you don't know me, I am the clinical program director of the Menopause and Midlife Clinic, where I work at the Brigham and Women's Hospital in Boston, Massachusetts. And I just want to let you know that anything that I say on this channel, those views represent my own, and this is not direct medical advice. It really is to you to be educational content to increase your understanding about things that are happening in the transition in your life from perimenopause to menopause. So today I want to talk about a really important topic, which is how to interpret your lab work. I get this question all the time, and it's a big part of what I do when my patients come to see me in the clinic. So we're going to go over that. So we're going to talk about lab work today and how to interpret your labs. Before we get started, I just want to let you know, if you don't already follow me, here are some of my social media platforms. I'm on Twitter at Heather Hirsch MD. I'm on Instagram at hormone.health.doc, and please check out and subscribe to my podcast, Women's Health by Heather Hirsch, where I talk about just all of the women's health things that I don't get to specifically to do, where this channel I am really committed to providing information and education on all things menopause and midlife, because I believe it is the area where we are lacking the most knowledge, advocacy, education, and research in women's health. Okay, with that all being said, let's jump into the juicy details of why you clicked on this video. So I want to go over lab work today, and I'm going to use the background here to give you some of the lab work that I think is really important. So let's jump right into it, and I want to start with what's actually the easiest thing to determine by lab work is menopause. Now, really crucial is that when I am seeing a patient, I use several things to determine where my patient might be in the menopause spectrum, be it early or late perimenopause, early or late menopause. And a lot of what I use also what the patient tells me, so that clinical history, meaning how long has it been since your last period, what are your symptoms. And so I suggest this in almost every video, but journal and track, journal and track, journal and track, because that's really going to help your clinician put your lab work into better perspective. But okay, so what are the labs in menopause? So I actually only check a very minimal amount of labs because it's unnecessary, number one, and really costly to run a slew of labs. It's probably not going to really tell you all that much. So what are the labs that I check? Here are the labs that I check when I'm looking to see if someone is menopausal. I typically start with a follicle stimulating hormone, or an FSH for short. Now, your follicle stimulating hormone is a hormone that comes from your brain. It goes down to your ovaries and tells them, hey, follicle, stimulate, ovulate. And so obviously, if you are menopausal and you're no longer ovulating, your FSH level is going to get really high. So your FSH no longer is directing your body to ovulate because your body knows that you are now menopausal. All the estrogen that you make comes from your ovaries, and it's pretty much closed down shop, and you are no longer ovulating. You are no longer able to get pregnant, right? Menopause, by definition, is your last menstrual period, a year from your last menstrual period. So an FSH level is going to be really high if you are menopausal, and it's going to be somewhere greater than 35. Now, I've seen levels of 37, I've seen levels of 102, I've seen levels of 120. Does that really make a difference? No, not necessarily, not really. It really doesn't actually mean that one's menopause is going to be worse, so far that we don't already know that that could be an association. It just means that if it's high, if it's over 35, you are menopausal. It is probably going to be higher if, say, you're 70 versus if you're 56 and your last period was at 50. But again, it's a little bit variable. It just means that you're menopausal. What else do I check? Well, I check an estradiol level, which is your estrogen level. And as you've been listening to me say, your estrogen is going to be really low if you are menopausal because you're not making any estrogen anymore. Levels of estrogen in blood work are usually somewhere between 0 and 20 for my patients who are in menopause. So I always say if I went to the local grocery store, if it was open and I could get all the women who were postmenopausal to get their blood levels checked, I'd get anywhere between 0 and 20. Some postmenopausal women do make a tad of estrogen, and that maybe comes from adipose tissue or adrenal glands, but overall it's really quite low. And I'm going to let you know this now, and I'm going to come back to it for perimenopause, but estrogen levels in a premenopausal woman are going to fluctuate anywhere from about 50 to 500 and go up and down each month. And that's how those fluctuating levels is how women ovulate. That's what allows us to get pregnant. And so levels are really, really high premenopausal. So 0 and 20 is pretty low. You're going to feel that effect most likely if you're menopausal. Other things that I do check on that list was a thyroid stimulating hormone level, and that's because I'm going to link my other video about thyroid diseases and thyroid conditions affecting perimenopause and menopause, but a lot of those symptoms are similar, and I never want to miss a thyroid condition and chalk it up to menopause or perimenopause when it really could be a thyroid condition. So I almost always check a thyroid. Those are actually the basic ones that I really start with. There's a couple more that I sometimes check, but not always, including an A1C level, which is a really good test to just check if you have any insulin resistance or prediabetes. That can be a reason people can get hot flashes. So I do check an A1C for that reason. Sometimes if the clinical history is worrisome for that, sometimes I check out prolactin. Prolactin can cause amenorrhea or a lack of periods in women, and if that level is high, that could be a concern that there's an issue with your prolactin gland up in your brain. It's much more rare, but occasionally if the history presents itself, I will check that. Testosterone, I did a whole video, so I will link that here as well. Testosterone levels I check particularly when my patients are complaining of changes in libido or low libido, changes in sexual function. If they are considering or thinking about adding testosterone replacement, again, you only want to use fairly low physiologic doses for women postmenopausal when you're using testosterone. And again, check out my video on that. I will check their testosterone levels as well. Things that I routinely don't really check, unless the patient and I have talked about it and we think it's important, because I never say never, but I don't routinely check a progesterone level. It's pretty low when you're postmenopausal, and the main role of progesterone is to protect an intact uterus from unopposed estrogen, which once you're menopausal, you really shouldn't be making enough estrogen anymore to be worrisome. Also to sustain a pregnancy. Once you're postmenopausal, your body knows you're not going to be getting pregnant, so progesterone levels are pretty low and they're not going to tell us very much. And I don't usually routinely check an LH level. A lot of my trainees ask me this, or folks from other disciplines like endocrinology or reproductive endocrinology and infertility. An LH level spikes really quickly before ovulation, and it's just so sporadic that an FSH is just so much more telling than an LH, so I don't waste the money on it. Another one that people ask me about is DHEA. This is a precursor androgen hormone. I don't usually routinely check that one either, but occasionally I do. Again, I never say never. So to summarize, if you are postmenopausal, you can have an elevated FSH, somewhere above 35, somewhere up to 100, a low estradiol level, somewhere between 0 and 20, and those are sort of the main ones that are going to distinguish. Again, if the thyroid's normal, prolactin's normal, A1C is normal, all those other things, you want to make sure you rule out any other chronic diseases. All right. Now let's talk about perimenopause. This one is so much more confusing because your body, or women's bodies, are still making some estrogen, but sporadically, and so it can really depend on what your body's doing at the exact moment that you get your blood drawn, which is why that clinical history, that piece, is so crucial when I, as a physician, and other physicians are kind of trying to figure out where you are. So an example is I have a patient who is having periods every 6 months or so, and it got from like every 3 months, 4 months, 6 months, So you're technically not menopausal until a whole year or 12 months from your last menstrual period. And so if you still keep getting a period, the clock's still going. Fun fact, the average age of menopause in the United States is 51 and a half. So some women are, you know, in their late 40s and some women are in their late 50s, and that's still pretty normal on that bell curve. All right, back to perimenopause. So let's take that patient who has not had periods in, 6 months. She comes to see me and she just happened to have a period, 2 weeks ago. So this can be a little bit muddied. Her FSH may come back on the lower side, say at 12, and her estrogen may be somewhere just kind of in the midst because her body just ovulated. So maybe it's 57 or 78 or something like that. Those labs are going to look more perimenopausal to me. But let's say she comes back in 4 months and said, Dr. Hirsch, my last period was that last one when I saw you. If I check her FSH, it now might be 30 or 28 or 40. And her estrogen might be 20, 27, 50. But we know that she's probably in that late perimenopause because those labs are starting to show that pattern, but it still hasn't been a whole year since her period. And that's where, as a clinician, I take into account what is the patient's age, what are her other medical factors, what else could this be? And so perimenopause can be more complicated than menopause, right? It's just not as straightforward. So more points on the graph is going to be helpful. So I might continue to follow her and check her labs. But again, those are going to be surrogate markers to what clinically is happening to her and to sort of what I'm thinking about in terms of other, other things. And again, I would still check that TSH level, maybe a prolactin level, maybe an A1C level, and those things as well that I mentioned, just to make sure I'm not missing something else. So perimenopause, more points on a graph is helpful. Going along with your clinical history is really helpful. And again, your estrogen levels and FSH can fluctuate where you are, like if you just had a cycle versus if you've had a pretty long, time between cycles, and that's when you're checking. So timing is everything. Now let's quickly talk about testosterone labs because I have a whole video on testosterone, but this is something that I do, check pretty routinely, not always. Again, I particularly am going to check testosterone levels if my patient is having sexual dysfunction, meaning low libido, and that's bothersome to her and distressing to her. So a free testosterone is sort of globally what I'm looking at, and the reference range for women is somewhere between 10 to about 45. Anywhere in there is considered pretty normal. Postmenopausally, women are going to lose their testosterone just like they do their estrogen, so testosterone levels do tend to go down to the lower spectrum. But the reason I do check that, there's actually two. If I'm going to start a patient on testosterone replacement for low libido, if her testosterone's already fairly normal, let's say it's 40 or 45, sort of in that higher spectrum of normal, it's probably a sign that it may not be her testosterone that's affecting the libido. Perhaps it's something in her life, with her relationship, with how busy she is, with other health concerns, etc. It may just not be the hormone component that is affecting her sexual function. And the second reason I check testosterone levels is sometimes at menopause, my patient's testosterone levels go up. And you might be like, what? Yes. A lot of my patients will say, why am I all of a sudden getting acne? Why am I all of a sudden, growing facial hair? Like, what's going on? It could be because your body is acutely stressed. Yes, and we all know that cortisol goes up when you're stressed, you're under significant stress, and when your adrenal glands, those cute little glands that sit above your kidneys, release that cortisol, sometimes they can also release testosterone. They are chemical structures that are pretty similar, and so your body can interpret and therefore metabolize that extra testosterone, which might give you that adult onset acne. Maybe that, maybe it contributes to either weight gain, that cortisol, or losing some of your hair. Could be some of that testosterone. So I also check testosterone as a measure of a stress hormone. Again, I'm never going to replace testosterone if your testosterone is already on the higher spectrum, or even in that sort of normal but still sort of at the tail end of that higher spectrum. It probably means you don't need any extra testosterone. So okay, Woo! That was a crash course on labs that I check to help distinguish my patients between perimenopause, menopause, and other medical conditions. I really want to stress to you that this is just what I do and how I have best learned to minimize just getting tons of labs for people. There's never one size that fits all. So some people do get other labs drawn. Perhaps we're looking for connective tissue disorders. Perhaps we're looking for autoimmune conditions. Perhaps we're looking for infectious disease, things like Lyme, etc. And so it's not always the same, but I do try to minimize it for my patients, as well as taking into account that clinical history, that story, so that also puts those pieces together. I'm sort of like your menopause detective. Whew. All right, that was a lot of information. I hope that was helpful. If it was, please leave me a comment below. Let me know what labs your doctor did or didn't check, how frustrated or excited that made you feel. And if this video was helpful, please give it a thumbs up, like it, and subscribe to my channel so I make more time to make these videos for you. I love doing this, and I'm just excited to help spread education as we open the dialogue on understanding midlife conditions and menopause. Thank you guys for listening in. Stay tuned next week for another exciting video. See ya.